Okay, so imagine your body's biggest, most important highways. Your arteries are suddenly being attacked by your own immune system. This isn't science fiction, it's a very real condition called large vessel granulomatous vasculitis. Today, we're going to dive deep into two major forms of this disease, giant cell arteritis and Takayasu arteritis. You'll see they have a lot in common, but the people they affect and the stories they tell are worlds apart.
So here's our game plan. First, we'll lay the groundwork. What exactly is this inflammatory disease? Then we'll get into the details of giant cell arteritis and how it's diagnosed. After that, we'll shift our focus to its counterpart, Takayasu arteritis. And to wrap it all up, we'll put them side by side to really highlight what makes them so different.
All right, let's start with the basics. What are we really talking about when we use a term like large vessel granulomatous vasculitis?
That name is a real mouthful, isn't it? Let's break it down. Large vessel is pretty straightforward. It tells us this disease goes after the big guys, the superhighways of your circulatory system, like the aorta and the major arteries that branch off it. Now, granulomatous, that's a clue about what's happening on a microscopic level. It means the inflammation is caused by these specific little clusters of immune cells, called granulomas, that are invading the artery walls.
Okay, so let's meet our first case study, giant cell arteritis, or GCA for short. You might also hear it called temporal arteritis. Now this one is a big deal because it's the most common type of vasculitis we see in older adults. And take a look at this. This image is really striking. What you're looking at isn't just a vein popping out, that's the superficial temporal artery, and it's visibly swollen and inflamed. This is a classic telltale sign of GCA. It's often tender to the touch, and you might have trouble feeling a pulse there. It's a huge visual clue that something is seriously wrong.
So who typically gets GCA? The patient profile is actually pretty specific. It usually affects people over the age of 50, and it's more common in women. But here's a really crucial piece of the puzzle. There is a very strong association with a condition called polymyalgia rheumatica, or PMR, which causes a lot of muscle pain and stiffness. And while the temporal artery is the classic location, you've got to remember this can also hit the carotid artery and even the aorta.
Just how strong is that link to PMR? Well, check this out. Somewhere between 40 and 50%, that's almost half, of patients with GCA also have polymyalgia rheumatica. That is not a coincidence. It's a massive clinical red flag. If a physician suspects one, they are absolutely looking for signs of the other. The symptoms themselves can be pretty alarming. A new headache that just won't go away is often the first sign. Then you might see something called jaw claudication. That's pain in the jaw when you chew because the inflamed arteries just can't get enough blood to those muscles. Perhaps the scariest is something called amaurosis fugax, which is a sudden, temporary loss of vision in one eye, often described like a curtain coming down. A doctor might also hear a whooshing sound, a bruit, in the carotid artery, or even find signs that the aorta itself is in trouble.
So here's a really important distinction to make. While a brand new headache is the most common symptom, lots of things can cause a headache, right? But jaw claudication, that pain with chewing, that is the most specific symptom. When a patient describes that, it points very, very strongly toward a diagnosis of GCA.
Okay, so you have all these clues pointing in one direction. How do doctors actually solve the puzzle? Let's walk through the diagnostic process for confirming GCA.
The first stop is usually blood work. You'll often see a sky-high erythrocyte sedimentation rate, the ESR. You can think of the ESR as a general alarm bell for inflammation in the body. A number over 50 is a huge indicator for GCA. You might also see elevated levels of interleukin-6, which is a key inflammatory molecule that's really active in this disease.
Next up, we can actually take a look at the artery itself with an ultrasound. See this image? Look at that dark ring surrounding the vessel. That's what we call the halo sign, and it's a classic finding in GCA. What you're seeing is swelling and fluid buildup in the artery wall because of all that inflammation. It's a very powerful piece of evidence.
So you've got the high inflammatory markers in the blood, you might see this halo sign on the ultrasound. The evidence is definitely mounting. But what's the one test that gives you that definitive, absolute gold standard diagnosis?
The final answer comes from a temporal artery biopsy. A surgeon actually removes a small piece of that artery so it can be examined under a microscope. But there's a catch. The inflammation isn't always continuous. It can be patchy. We call these skip lesions. So to make sure they don't miss the diseased section, the surgeon needs to take a decent-sized sample, at least a centimeter long.
And this is what the pathologist sees. The difference is just night and day. On the left, you have a nice, healthy artery with its well-organized layers. But on the right, it's chaos. In GCA, the artery is a battleground. You can see this massive thickening of the inner layer, something called neointimal thickening, that is literally choking off the space where blood is supposed to flow. It's incredibly destructive.
And if we zoom in even closer, this is where giant cell arteritis gets its name. See those huge blob-like cells with multiple nuclei? Those are the culprits. Those are the giant cells, a hallmark of the disease. And for a pathologist, seeing these is a dead giveaway.
To get an even better view, pathologists can use this special stain. It's designed to highlight the elastic fibers in the artery wall. In a healthy artery, this layer, the internal elastic lamina, should be a nice, continuous black line. But look here. You can see it's been shattered, it's fragmented, and broken apart by all the inflammation. It's just another piece of proof of how damaging GCA is.
Now, this is absolutely critical. You cannot wait for the biopsy results to come back before starting treatment. The second GCA is suspected, especially if the patient has any visual symptoms. They are started on high-dose IV steroids immediately. This is a true medical emergency because the #1 goal is to prevent the single most feared complication, permanent, irreversible blindness.
Okay, let's completely switch gears now and talk about our second case, Takayasu arteritis. This one has a pretty chilling nickname, the pulseless disease, and that name alone tells you a lot about this condition, which, completely unlike GCA, typically strikes young people.
What you're looking at here is an angiogram. It's essentially a roadmap of the arteries, and this picture is really stark. Do you see those areas where the major vessels coming off the aorta look pinched and severely narrowed? That's called stenosis, and it's the signature finding in Takayasu arteritis. This narrowing is what causes all the devastating symptoms of the disease.
So the patient profile for Takayasu is pretty much the mirror image of GCA. We're talking about young patients, typically women under the age of 40, and the disease targets the body's biggest arteries, most commonly the left subclavian, which supplies blood to the left arm. This is what leads directly to that weak or absent pulse and a big difference in blood pressure readings between the two arms. The inflammation can also cause everything from strokes and sudden blindness to dangerously high blood pressure if the arteries leading to the kidneys get involved.
When it comes to diagnosis, the findings under a microscope are actually quite similar to GCA. You'll see granulomas. But the real key here is radiology. A CT or MR angiogram gives that definitive confirmation of the narrowing in the aortic arch. And for treatment? Well, once again, the first line of defense is steroids.
So there we have it. Two diseases with the same basic mechanism, inflammation, but with totally different targets. Let's put them head-to-head one last time to really nail down what sets them apart.
This table really lays it all out beautifully. First, the age of onset is the clearest difference, over 50 for GCA, under 40 for Takayasu. Then, look at the vessels they attack. GCA goes for the branches of the carotid, like the temporal artery. Takayasu goes for the massive aortic arch and its direct branches. This difference in location leads directly to their key symptoms: headache for GCA and a weak or absent pulse for Takayasu. And that in turn dictates how we diagnose them. Biopsy is the gold standard for GCA, while imaging is the key for Takayasu. The one great unifier? Treatment for both starts with steroids.